me share this fantastic meeting. I had the opportunity since a couple of years to use a very interesting instrument as a degree of accuracy that I think might be very useful for all our surgeries, from refractive to corneal surgery to cataract surgery. These are my financial disclosures. Talking about OCT, we should think just for a moment about how the frequencies have been chosen. And there are so-called windows, imaging windows for the living tissues that are useful and where less absorption is there. For anterior segment OCTs, usually is 1300 nanometers. And a big advantage of this resolution, and you see here, this is the first spectral domain OCT, came out around the year 2000. This was the first model. With the second model, the Casia 2 by Tomei. It's a beautiful machine. I had the opportunity to work first with this one already in the year 2000, did some research on that. And with the new machine, you can get the whole segment, anterior segment, together with the crystalline lens. And 300 nanometer is 1300 nanometer is good because it goes through tissues pretty well. You see here, you can almost see the ciliary muscles. But to see that really, you need to do what Marco Ruggeri at Bascom Palmer is doing. That is using a higher power OCT, and there, with the lateral OCT, you can even imagine the ciliary muscles in such a beautiful detail and study accommodation very well. But in other situations, maybe, this is not that useful because anyway, even with 1300 nanometers, you can go through the iris pigment epithelium, so we cannot get much more information. I'm trying, oh, here. Another possibility, which is quite interesting, is exploring the 830 nanometer. This is much closer to visible light, and this also has very good advantages, I think, for our work, because you get higher resolution, and being closer to the visible light, any minimal thing that is there in the cornea that is not transparent, you will see very, very well. And you see the level of detail is really better. The resolution is that high. And as I've had the possibility of working with the Casia OCT before, in the very beginning, when I was seeing this kind of image, that had really a wow effect to me. But now, when I see images like that, now again, wow effect, because the improvement in resolution is really incredible. You can see all the details. This is the site of a biopsy for limbal transplantation, something that I was talking yesterday. This is the epithelium that is very well delineated. You can go even deeper, although not together, and get some relevant information about tilting, sizing, curvature of the lens, whatever we might need for advanced IOL calculation, for example. And combining the higher resolution anterior segment OCT with the plastido disc, you not only get detailed morphology of the whole cornea anterior segment, but we can get very precise corneal topography, because this is sampling in 25 sections automatically, plus here the placido disc, and I think of more than 30,000 points in the front of the cornea and more than 25,000 points in the back of the cornea. So it's much higher than many machines that are pieces of equipment that are intended for studying the cornea for IOL calculation, for example, or for corneal surgery. In the anterior segment, we can measure whatever we want, all the distances, but also we have an interesting feature that is dynamic behavior of the pupil, of the IOLs, and even the tear film with the high resolution objective recap time analysis. I want to show just very quickly, because where should I point this to change? Yeah. This was funny. This was actually taken with my phone. The video was not, it was 2 years ago, was not yet there. This is a fibrin membrane in the pupil that I found the day after a cataract surgery. It disappeared the next day with therapy. It's beautiful because using a placebo disc, switching on the light, you get the pupil constricting and you see what happens to the fibrin membrane. And this is, of course, the IOL standing behind with the vitreous. Maybe the batteries, no? This is also very nice. Besides looking at the angle, it's very nice to have a look at what happens to an ICL with quite a bit of vaulting, and you see what happens when there is constriction with light. This is some information that might be very useful to have. Besides the measurement that can be done anyway. Now this is little annoying. Talking about the epithelium, this can be studied very in high detail because it can really be imagined accurately. And this is a case of a keratoconus. We see also some stromal alterations. This is after corneal cross-linking. And this is after deep anterior lamellar keratoplasty. You can see, although it's after a few years, the margins very well and the epithelium as well. It's very important knowing better what happens at the level of epithelium in refractive surgery because it can avoid us making terrible mistakes. For example, in this situation, there is something that is not perfect, and that is keratoconus, of course, and I can't read. And you see how I can't read from here really. Excuse me. I counted on being able to read it. Yeah, now also the image is not great. The epithelial thickness, you see how is much thinner at the top of the cone. And of course, if we think of planning customized treatments, that's very important because we all know that the ablation rate of the epithelium is different from other parts of the cornea. So in the future, it will be possible to have lasers that are linked to this kind of equipment in order that the transepithelial treatment can be customized in an actual way and not just hypothetical. More advanced keratoconus. I'm sorry, I'm losing time. And where, of course, you see that the epithelial map is more altered than before. And this is, you see very well, here is something wrong going on. You wouldn't see that on the map, but on the anterior map, at a higher definition, you see very well how thick here were erosions many years ago before the patient had keratitis. And you see how they are very well found in the epithelial map. So this is very important to take into account if we think of treating with laser this case. This is after myopia treatment. You see that the flattening, the central flattening, and the epithelium gets thicker here in the center, where is a kind of valley. But this also It's also in myopic treatment, but the epithelium is doing exactly the opposite thing. So it's thicker, corresponding to this. And this is because it's not after laser, but this is after orthokeratology. So the contact lens made on purpose, the epithelium get thicker on the annulus in order to modify the curvature. And we can follow all these things very correctly. In this case, it's a courtesy by Dr. Frankel last year. We see here something strange on the front surface. The rear surface of the cornea is reassuring, but this is still something that we would not like to see, and we would invite the patient to stay without contact lenses for a long time in order to be sure that that's a warpage. But if we go to imaging with the OCT, we can see very well how the reason for this. And you see the epithelium has a different thickness in the superior as compared to the inferior part. This is compensating for the difference in curvature. Talking about epithelium, it can be imagined also in other situations, like this is line keratopathy, and at higher definition, we can see that there are some thickenings of the epithelium. That's why the patient has pain sometimes, and this is after PRK, but not in. We see very well what's going on. A little haze, but not in very center, so the patient is not disturbed. It's very useful to have a better knowledge of what's going on also in laser surgery. This little ingrowth after LASIK, otherwise the interface is beautiful. And this is after hyperopic LASIK. Again, the interface is fantastic, but it's not always like that. This is a beautiful interface. This is a patient after a smile. You can hardly see anything here. But if we go 135 degrees, where I enter to take out the lenticle, then you can see the entrance side. But what I found really very interesting is that when you have problems, this is my case, the patient was not seeing 6.5 like the other one. Actually, it was the fellow eye of the same patient. And there is a reason for that in the interface. It will take a few months to get better and perfectly transparent. And there is, at this resolution, there is a beautiful correspondence between this and what we see on the OCT. This, then I want to go quickly to, it's a subepithelial problem. This is keratitis. And this was interesting, a recent case. The patient had the PK many years ago, was decompensated, and didn't want to perform PK again, so we went for DSEC, and after that I performed the OCT, and you see how the epithelium here is thick, but below the epithelium there is not just the anterior stromal opacity that is typical of bullous keratopathy, but also something else that is more typical for PRK. In fact, I asked the patient who didn't tell that to me before, and he admitted that he had PRK after the PK many years before, and so it was very useful having the epithelial map to compensate for some unusual thickness of the epithelium. And we made a custom PRK, and the patient, besides he has quite a cataract, went very well. It's already would be 2 to 3.6, so 2015, and was very useful also in this case, having the possibility of knowing in advance exactly was going on in the map of the epithelium on the stroma and so forth. Thank you very much for your attention.
Thanks very much, Claudio. You showed some beautiful images there with the OCT. Do we have any questions? Any questions from the audience? Claudio, can I ask how you think the application is now we're getting high resolution and we can actually measure the epithelial thickness maps on OCT, how we apply that to trans-PRK, and whether you would change, if you say get thicker than normal, would you be having the confidence to change your parameters on trans-PRK profiles?
Yeah, of course, in performing trans-PRK, the ideal would be that the equipment, the laser, knows exactly when doing the first step, that is ablation of the epithelium, what is the thickness in the different areas. At a reasonable resolution. Otherwise, for example, in a keratoconus, maybe 40 years old, we want to improve his vision. We do beautiful simulations of what's going on. A few micron are enough to get much better, a good improvement in the curvature of the central cornea. And we want to go with that, but we have to be very careful because the ablation rate in the epithelium and stroma are different. So if we know that, we can use that data. If we don't have those data, we have to do other things and go step by step.
Yeah, that's great. And I mean, in Australia, we see high rates of ocular surface squamous neoplasia, and it has been described, using high resolution anterior segment OCT to actually differentiate between a pterygium and epithelial dysplasia. Does anyone in the audience have any experience with that, or with using high resolution AS-OCT to distinguish between OSSN and pterygium? No? I've just read a few reports on that. I was just wondering if anyone actually practically does that, or if you go by clinical diagnosis, but I guess it's an evolving field.
And how are you treating, if you do diagnose, a surface cancer? What's your treatment here? Is there are you guys usually excise it, or do you guys use interferon alpha 2b, or what do you guys usually do?
I think we do both. So it's either topical chemotherapy, interferon, retinoic acid ointment, or mitomycin C, or an excisional biopsy with cryotherapy, etc. So I guess you're right. At the end of the day, usually if there's a suspicion, we would do some sort of tissue diagnosis, either impression cytology or. Because I've tried using the OptiView a few times to try and image a suspected OSSN, but I haven't had enough convincing information to tell me otherwise, and it usually is a clinical judgment at the end of the day.
They do melt away so easily with medication. Interferon alpha 2b, they typically will go away over a couple weeks to months. Sometimes I'll start that. In South Florida, we have a lot of UV like you have here, so we just started empirically without a tissue diagnosis, and it's gone in after a couple weeks to months, and then we know we're on target.
Thanks, Bill. All right, so
maybe this kind of imaging may be useful only as a quantitative information follow-up, such things, not for diagnosis. That's different. It's biology.
Thank you. So now we've got Raina.